Welcome to this Step 3 review on gastrointestinal bleeding management. This video is brought to you by Roadmap to Residency, your home for expert tutors and residency advisors. Before we dive in, please like this video and subscribe to the channel so you never miss our board review content, and head over to roadmaptoresidency.com to connect with a tutor who can build you a personalized study plan. Here is the promise of this video. We are not going to reteach all of gastrointestinal bleeding from the ground up. Instead, we are going to focus on how the test writers build these question stems and how you can attack them quickly and correctly on exam day. We will cover how to triage stability and decide on resuscitation and transfusion when proton pump inhibitor therapy is the right move, how to time endoscopy, and how to recognize and treat variceal bleeding with octreotide and band ligation. For the underlying content, lean on your question bank and a trusted review resource, and use this video to sharpen the test-taking instincts that turn knowledge into points. Here is what we are going to cover today. First, we will learn to triage stability before anything else, because in a bleeding patient, the test almost always rewards you for stabilizing first and scoping second. We will talk about resuscitation, transfusion thresholds, and deciding where the patient belongs. Second, we will sharpen your radar for the next best step, whether that is starting a proton pump inhibitor, calling for endoscopy, or reaching for variceal therapy. Third, we will train you to spot the classic buzzwords that flag a variceal bleed, which immediately point you toward octreotide and band ligation. Throughout, remember the division of labor. Your question bank and your review resource teach the content. This video teaches you how to apply that content under time pressure on test day. Let us get started. Our first strategy is to stabilize before you scope. In any bleeding vignette, train your eyes to jump straight to the vital signs. A low blood pressure, a heart rate above 100, or a blood pressure that falls when the patient stands up are all telling you the patient has lost a meaningful amount of blood. The moment you see instability, the question changes. The right answer is almost never a fancy diagnostic test. Instead, the next best step is to support the circulation. Place 2 large bore intravenous lines, give fluids, and transfuse blood when it is needed. On step 3, you earn points by resuscitating first and investigating second. So when you see an answer choice that rushes an unstable, actively bleeding patient straight to imaging or straight to the endoscopy suite before any resuscitation, treat it as a trap. Stabilize the patient, then figure out where the blood is coming from. Strategy 2 is to locate the bleed using the clues planted in the stem. The test writers always tell you where the blood is coming from if you read carefully. Vomiting blood or passing black, tarry stool points you to an upper source, somewhere above the junction between the small intestine and the large intestine. Bright red blood from below usually points to a lower source. Now here is the high-yield move. Whenever the stem drops in alcohol use, known liver disease, a swollen belly with fluid, or an enlarged spleen, your antenna should immediately go up for a variceal bleed. That one detail is not background color. It is the test writer steering you away from the standard ulcer pathway and toward variceal management with octreotide and urgent endoscopy with band ligation, if the stem instead emphasizes a painful ulcer history or chronic use of a pain-relieving medication. That points you toward an ulcer and toward proton pump inhibitor therapy. Read for the source, and the right treatment follows. Strategy 3 is about sequencing and appropriate care, which step 3 weaves into a huge number of bleeding questions. First, remember the order of operations, support the circulation, start the right medication for the suspected source, and then arrange endoscopy at the appropriate time. When 2 answer choices both look medically reasonable, the better answer is usually the one that respects this sequence instead of skipping a step. Second, match the medication to the source. An ulcer or another upper source points to an intravenous proton pump inhibitor. A suspected variceal bleed points to octreotide together with a preventive antibiotic. Picking the drug that fits the source is frequently the one detail that separates the correct answer from a tempting distractor. Third, beware the premature procedure answer. The test writers love to dangle an aggressive option, like immediate surgery or an emergent invasive intervention, before the basics are even done. It feels decisive and thorough, but on this exam, leaping to the procedure before resuscitation and first-line medication is usually the wrong move. Choose the step that fits the moment. Let us work through our first practice question, and this one is built to test your resuscitation instincts. A 60-year-old man comes to the emergency department after vomiting bright red blood twice at home. He takes a daily pain-relieving medication for arthritis, which is a hint toward an ulcer. But look at his numbers. His blood pressure is 85/50, his heart rate is 120, and he is pale and sweaty. The last line asks for the most appropriate next step in management. Pause here and pick your answer. Your choices are an immediate upper endoscopy, placing 2 large bore intravenous lines and beginning fluid resuscitation, ordering a computed tomography scan of the abdomen, or starting an oral proton pump inhibitor and admitting for observation. Notice how every wrong option is a real thing you might eventually do. The question is what to do right now, at this moment, for an unstable bleeding patient. Let us break this down step by step. First, spot the pattern. The vital signs are the entire story: a blood pressure of 85/50, a heart rate of 120, and a pale, sweaty patient all describe someone who is hemodynamically unstable and losing a significant amount of blood. The daily pain-relieving medication is a clue that the source may be an ulcer, but right now the source matters less than the instability. Second, apply the rule. In an unstable bleeding patient, you resuscitate before you investigate. The correct answer is to place 2 large bore intravenous lines and begin fluid resuscitation, transfusing blood as needed. Third, eliminate the wrong answers. Immediate upper endoscopy is wrong because scoping a patient who has not been resuscitated is dangerous and the field will be poor. A computed tomography scan simply delays life-saving care and will not change what you do in the next few minutes. An oral proton pump inhibitor is far too slow and passive for a patient who is crashing. The answer is to place 2 large bore lines and begin fluid resuscitation. Stabilize first. Now let us tackle a variceal bleeding question because the test loves these. A 55-year-old man with a long history of alcohol use and known liver scarring is brought in vomiting large amounts of blood. He has a swollen abdomen and an enlarged spleen. Those details are not decoration. They are screaming variceal bleed. Importantly, the team has already done the right first move. 2 large bore lines are in, fluids and blood are running, and his blood pressure has improved. So the last line asks what medication is most appropriate to start now. Pause and choose. Your options are an intravenous proton pump inhibitor alone, octreotide together with a preventive antibiotic, a beta blocker to lower the heart rate, or no medication until endoscopy is performed. Think about which drug actually matches a bleeding varix, and remember that there is a second medication these patients always need. Let us walk through it. First, spot the buzzwords. Alcohol use, known liver scarring, a swollen abdomen, and an enlarged spleen are the textbook flags for a variceal bleed. The test writer planted every one of them on purpose. Once you recognize that pattern, and once the patient is being resuscitated, the question becomes which medication matches this specific source. Second, match the drug to the source. For a variceal bleed, you start octreotide, which lowers the pressure in the bleeding vessels, and you pair it with a preventive antibiotic, which has been shown to improve survival in these patients. That combination is the answer. Now eliminate the rest. A proton pump inhibitor alone treats an ulcer, not a varix, so it does not fit this source. A beta blocker is used to prevent future bleeds once things are stable, not to stop an active one. And giving no medication while waiting for endoscopy abandons a treatment that works. So the answer is octreotide plus an antibiotic, and the next definitive step after that is urgent endoscopy with band ligation. Let us talk about endoscopy timing and transfusion limits, because both are favorite testing points. First, timing. For most upper gastrointestinal bleeds, the goal is to perform endoscopy within roughly 1 day of the patient arriving. But, and this is the key, only after the patient has been resuscitated. Endoscopy is powerful because it both finds the source and treats it, but it is never a substitute for stabilizing the patient first. So if a STEM describes a patient who is now stable and well resuscitated, timely endoscopy is frequently the next best step. Second, transfusion limits. Step 3 rewards a restrictive transfusion strategy in most stable bleeders. That means transfusing toward a lower target rather than trying to reach a perfectly normal blood count. Be suspicious of any answer choice that chases a completely normal blood count in a stable patient, because over-transfusing is a classic overkill trap on this exam. The evidence supports holding back, not piling on. Right care, right amount, right time. Here is our third practice question, and it pulls together proton pump inhibitor therapy and endoscopy timing. A 70-year-old woman comes in with several days of black tarry stool and a known history of stomach ulcers. The black stool points to an upper source, and the ulcer history points to the likely cause. Crucially, her blood pressure and heart rate are normal and stable, and she is comfortable. Access and fluids are already started. The last line asks for the most appropriate next step in management. Pause and choose. Your options are to start an intravenous proton pump inhibitor and arrange endoscopy, to transfuse blood until her blood count is completely normal, to take her to immediate surgery, or to discharge her with an oral antacid and outpatient follow-up. Think about what a stable patient with a likely bleeding ulcer needs, and watch for the overtransfusion and premature procedure traps. Let us break it down. First, read the stability. Black, tarry stool together with a known ulcer history points clearly to a bleeding ulcer in the upper tract. But the detail that drives this question is that she is stable and comfortable, with normal vital signs. A stable bleeder is handled very differently from an unstable one, and that stability is exactly what makes a measured, evidence-based plan the right answer here. Second, choose the right pair. For a stable, suspected ulcer bleed, you start an intravenous proton pump inhibitor and you arrange timely endoscopy to find and treat the source. That is the answer. Now eliminate the distractors. Transfusing until her blood count is completely normal is the overtransfusion trap we just discussed, and it is wrong in a stable patient. Taking her to immediate surgery is far too aggressive before you have even looked with a scope, and discharging an actively bleeding patient with an antacid is unsafe. So the answer is to start an intravenous proton pump inhibitor and arrange endoscopy. Treat, then look. Here is a test-taking pearl that ties everything together into a simple decision tree you can run on every bleeding question. For each bleeding stem, ask 2 questions in order. First question, is the patient stable or unstable? Check those vital signs immediately. If the patient is unstable, you go straight to resuscitation and transfusion, and any answer choice that delays that with a diagnostic test or an early scope is a trap. Settle stability before you even think about the source. Second question, once the patient is stable, is this a routine upper bleed or a variceal bleed? Look for the liver clues. Alcohol use, known liver disease, a swollen belly with fluid, or an enlarged spleen all flip you into variceal mode, which means octreotide, a preventive antibiotic, and endoscopy with band ligation. If those clues are absent and you see an ulcer or pain medication history, think ulcer, which means an intravenous proton pump inhibitor and timely endoscopy. Stable or unstable, then upper or variceal. Run that tree every time, and these questions become almost automatic. That wraps up our review of gastrointestinal bleeding management for Step 3. Remember the core ideas we covered today. Stabilize before you scope, because an unstable bleeder needs resuscitation and transfusion before any test. Locate the source from the stem, and let liver clues flip you into variceal mode with octreotide, an antibiotic, and band ligation. For a stable upper bleed, reach for an intravenous proton pump inhibitor and timely endoscopy, and resist the overtransfusion and premature procedure traps. To make all of this automatic, drill bleeding cases in your question bank, read every explanation even when you got the question right, and confirm the key thresholds and steps in a trusted review resource. Keep practicing under timed conditions so the decision tree runs on its own when it counts. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized plan. If this video helped you, please like and subscribe for more board review content. Good luck on your exam, and we will see you in the next one.